This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2017, all rights reserved. My name is Doug Lair. I'm a registered respiratory therapist and Associate Executive Director at the AARC. I welcome you to today's presentation, Vibrating Mesh Nebulizer Compared with Meter Dose Inhaler in Mechanically Ventilated Patients. Upon completion of this AARC webcast, participants will be able to, 1, identify the research question of the study, 2, identify the study design, 3, discuss the main results of the study, and discuss the implications of the study on patient care. I am pleased to welcome Dr. Lynda Goodfellow. Dr. Goodfellow is a registered respiratory therapist, certified asthma educator, and fellow of the AARC. She is a professor of respiratory therapy and the Associate Dean for Academic Affairs at the Burdine F. Lewis School of Nursing and Health Professions at Georgia State University in Atlanta. Dr. Goodfellow has published several articles and book chapters and is active with the AARC, most recently serving as past chair of the education section and as the Vice President of Internal Affairs on the AARC Board of Directors. She was the 2013 AARC Education Section Practitioner of the Year. Dr. Goodfellow has no relationships to disclose. I do disclose, however, that I am a paid employee of the AARC. Brand names of products and or medications may be mentioned only as examples of technology. Any use of brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis and to provide information and education regarding the availability. Dr. Goodfellow, welcome to today's program.
Well, thank you, Doug, and I appreciate that nice introduction, and I want to say thank you to the AARC for this opportunity today of presenting this journal webcast. And I have to say, I look to see that I've got a number of former graduate students and colleagues that are on, so I want to say welcome to you and thank you for joining, and then to all the other respiratory therapists who are on. So hope to have a good session here and answer any questions that you may have towards the end of the session today. So let's get going here. We talked about Doug mentioned the article and the title there. So let's just get right down to what are the research questions here that are being addressed. And even though we don't see it in the title, we do see in the abstract and also really the first sentence of the article that the question is there a difference in VAP occurrence and patient outcomes between the vibrating mesh nebulizer and the meter dose inhaler? And two of the outcomes that we'll call them, or two variables that they're looking at, are the days on the mechanical ventilator and also the in-hospital mortality. So they're going to use those two characteristics, those variables there, to really get to the question and answering the question of, is there a difference between the mesh and the use of an MDI? So let's look at what is known about this subject to begin with. And the article does provide a short lit review, and there are key articles I want to make highlight that they also mention. And that is the impact of aerosol therapy on patient outcomes during mechanical ventilation is really not known. We have limited choices with the devices that we're using in line to provide aerosol therapy. We have the pressurized meter dose inhalers, the traditional jet nebulizer, and now in the past 10 years or so, the vibrating mesh nebulizers. And the one studied in this particular article was the AeroNeb Solo. So what do we know as we go further into the literature? That the greatest drug delivery has been found with NDI actuation when it's synchronized 1 second before inspiration and it's not at the start of exhalation. You see a footnote there. Instead of listing out the references at the bottom of each slide, you've got a copy of the article yourself, so you can look in the reference list to get the author that corresponds to these little bullet points here that I'm referring to the past literature. Other studies suggest that MDIs can be just as effective as jet nebulizers. MDIs, we know them to be very convenient, and perhaps the literature tells us that it can reduce the risk of bacterial infection. And certainly the MDIs can provide some cost savings, particularly with the common canister protocols that are used. And it's been found so far to not increase the risk of cross-contamination. And then other things that we know from the literature is that any type of artificial airway that's introduced into the body reduces the, can reduce the efficiency of a device here whenever these artificial airways and the circuitry and all those kinds of things are factored in. And the type of the MDI adapter can affect the drug delivery to the patient. And we are familiar with this by being able to deliver more drug when a holding chamber or some sort of spacer device is used versus just a simple elbow adapter, which can really impact the drug delivery. And so that's been documented in the literature. The addition of heat and humidity and bias flow have all been explored, and how this affects the circuit in terms of aerosol loss. And that's reviewed, as well as the position of the device in the circuit. And a couple of studies have looked at the best position on the inspiratory limb, and there's a couple of things that we see from bench studies is if you place the device 15 centimeters to the Y piece, except for the jet neb, because of the continuous flow in aerosol in the expiratory limb, that affects the efficiency of the device as well as the amount of drug delivered. So those are a couple of things that the article goes through. And then the last thing, they really get down to comparing what's known about the jet nebulizer and the vibrating mesh. And this is tested on the dry side before the heater, and then between the Y piece and the inspiratory limb. And they found two things, that both devices delivered more drug before the heater. And again, the bias flow is accounted for there. And then the vibrating mesh delivers more drug than the jet neb. So those are two specific studies that relate somewhat to this current article that we are discussing here today. So overall, our current knowledge is very limited, because even though we've looked at position, we've looked at aerosol deposition, we've looked at a number of other things here, we really have no outcome data in terms of patients, in terms of the patient outcomes. We know that with our aerosol therapy that we're treating symptoms, but really when we relieve these symptoms, is when the drug is indicated, what does the other outcomes, what is impacted in terms of outcomes from that point, and that's what has not been studied thus far. And then lastly, does the vibrating mesh reduce the length of mechanical ventilation or the hospital stay? And that kind of gets back to our research question again. And so because VAP is such a concern in our ICUs, the article goes into a little bit about what is known about VAP and for patients who are on mechanical ventilation. They cite several sources that document the association of VAP with higher mortality rates, which because of the sickness there and the acuity, we see an increased length of stay. Because of that length of stay, there's a significant increase in cost of care. VAP has been linked to contaminated aerosols in the circuits, mainly due to the manipulation and the open and closing of the circuits for inline medication delivery. VAP has also been associated with secretion drainage into and around the endotracheal tube. And then even the vibrating mesh medication cup with that opening and closing, even though it's on the dry side of the circuit, that has been in the literature documented for an increase in VAP as well. So taking what we know about VAP, what we know about aerosol therapy, we again come down to, is there a difference in VAP occurrence and patient outcomes between the vibrating mesh nebulizer and the metered dose inhaler when you look at days on ventilator and the in-hospital mortality? I hope we all are aware of what our research question is here. The slides that I was provided here, I'm following those, and here we go to conflict of interest. And so for any of us reading an article, we should ask ourselves, is there any concerns about conflict of interest among the authors and the research that they are presenting? And we do have a couple of disclosures here. This research was supported by Aerogen Incorporated, and the work has been supported by the National Center for Advancing Translational Sciences, which is through the NIH, and the grant specifically that was tied to this project is listed there. Now, two of the authors list the conflicts of interest, or disclosures, I should say, with Dabowski and Vines. They both list particular vendors that they have a relationship with, if you will, probably through consulting or other things. So that is disclosed. Going into the methods now. So as I teach here at Georgia State, anytime you really look at the methods, the first thing you should see is the study design, and that sort of sets a frame of reference whenever you, from this point, try to understand the research, and the ultimate goal is to replicate this whenever you're writing for publication, and you need to explain your methods so that if someone wanted to replicate your experiment in the future, they would know exactly how to do so. So a retrospective study here is what we have, and generally what that means is that they have gone back through patient charts, or in this case the electronic health record, and collected data or extracted data from these files, and are using those as part of their data collection so that they can possibly answer the question that they've set out to investigate. And because of the retrospective design, they had to come up with some criteria that was appropriate for the question. And so they decided to include any patient record through the electronic health record of all mechanical ventilated adult patients who received an order for aerosol therapy. And they have a 2-year time frame here of August 2011 through August of 2013. And so why did they choose that particular time frame? And again, adult patients on mechanical ventilation who received an aerosol order. Well, it was pretty timely in terms of the time frame here, and that was because they converted, or they had a policy of converting the MDIs to the vibrating mesh starting in August of 2012. So whenever after all this was over, they went back and said, okay, let's go back and look. They said August 2012 is conversion, so they went 1 year into the past. In other words, 1 year before the conversion policy went into effect, and then they looked 1 year past the time of the conversion. And so that's how they came up with their inclusion criteria. For exclusion, any patient who was trached on mechanical ventilation for less than 24 hours, they were excluded. If there was a combination of MDI and NEB treatments ordered or administered, then those patients were excluded. And then if any patient was extubated or reintubation during their hospitalization, then they were excluded from this data collection. So going on from that, the questions to next ask, once you know the study design and who's included and who's not, is what is the control group? Well, generally for retrospective studies, you don't have one, because you don't have, in a prospective study, we'll say, where you do have a control group and then you have your intervention group. That was not the case as they went back into time and gathered the data that they were looking for here. So they did collect, though, patient demographic information, a primary diagnosis code. We'll see why that's important in a second. The drugs that were used and the dosage that was delivered, the number of aerosol treatments that were received on mechanical ventilation, the number of days on mechanical ventilation, the in-hospital mortality, and then the incidence of VAP. And they used a confirmed diagnosis of VAP if there was an ICD-9 code listed, and you can see the VAP code that they were particularly looking for. And I'll say with electronic health records now, it's easy to sort of sort your diagnoses by these ICD-9 codes, and so there it was, 997.31. The article goes on to explain that this was confirmed by CDC criteria based on imaging, clinical findings, and laboratory findings. If you've read the article already, you know that there's more to this definition now. In fact, you're not just looking for VAP anymore, but ventilator-associated events and things like that, and we'll talk about that. So they do make reference that the code that they used or the way that they looked for the incidence of VAP in this retrospective study is a little different from how ICUs may be treating and looking for VAP these days. So now we know the characteristics of and the demographics of the patient that they were looking for. And as they get, our next slide and figure will show they needed to exclude and come to a algorithm, if you will, of a sample size. And so from their exclusion criteria used, they came to 288 cases or charts that were retained. The others were excluded. You can see a total of 2,905 charts were reviewed total, and 2,677 of those were excluded. So that's where you get your 288, and that becomes your sample size. When you're reviewing literature, and particularly the methods, a question to ask is, was a power analysis performed? And what that means is, was the sample large enough to really be able to test for significance on your particular research question here? Because that's important. You don't want a study that's underpowered. And one that, in other words, because of, you don't want to overpower either, because resources are so precious, I'll say, or we want to be efficient with the resources that we have, that once you get to a particular point in your sampling, and that's sufficient for you to be able to test for significance, you don't want to keep oversampling. So it's important to either be cognizant of undersampling as well as oversampling. But with 288, it seemed like to the researchers here that was an adequate number. No power analysis was performed, but you do have to be careful, even with retrospective studies, about any threats to validity to your research design, because analysis bias may come into view. And this is this analysis bias is when you have your results and you sort of think you know already what the results are going to be, and that can be a problem in terms of validity here. So some studies may stop too soon because, we know what we're seeing here, there's no need to keep sampling. That's not the case here. I'm just using this as an example of questioning about the sample size. And so let's look at Figure 1 so we can really understand how they drilled down to the 288 cases. And so we see here all the charts that were reviewed, the 2,905, and then the exclusion criteria to the right box there, the subjects that were enrolled, 228, and then of those that were enrolled, we see that only 48 of them were receiving meter-dose inhaler only, and then 180 of those were receiving the vibrating mesh. And we'll talk about the differences in those subgroups there in a second. But I think they did a good job of displaying their thought processes and their methods here of in getting down to their sample size. So just for reference here, so everyone has sort of a visual of what we're talking about here, the diagram on the left will be the MDI that's inserted through an adapter in line. This particular drawing's got a holding chamber or a spacer device, and that's the delivery mechanism of drug delivery for this particular picture. And then the one on the right is the vibrating mesh nebulizer, and you can see the cap there that's sort of coming off to the left there. That's what you would open, inject the medication, close that port, and then it would be nebulized through the nebulizer, the humidifier, and then through the inspiratory limb. All right, next we go into the statistical analyses, and the authors here list a number of tests that they used. One, we see categorical variables that they were analyzing for, and that was particularly for frequencies and percentages. A continuous variable, which was able to provide mean data. They also employed the chi-square test for correlations, particularly when they were looking at differences between the MDI patients versus the vibrating mesh patients, and other covariables as well with the chi-square test. They also mention a Wilcoxon-Rank sum, and this is a continuous variable to account for skewedness. And so I mentioned the two groups. Remember, the MDI group had a very small N. There were 48 subjects there, patients who received the MDI, and then 180. So on the surface, that's quite a difference between the two. And when you want to make comparisons between two different groups that have a very uneven or skewed distribution, then the Wilcoxon-Rank helps to sort of normalize that, so that when tests of significance are employed, you can come up with reliable findings that way. So that test was important. And then lastly, they present two tables where regression analysis was performed. Here they were looking at VAP and mortality, and specifically if the number of days mattered, the total aerosol treatments, age, Apache score, their diagnosis, and gender. And we'll talk more about those when we look at those tables. The statistical program that they employed was the SAS. That's just as good as SPSS. It's just a different type of analysis program, statistical analysis. And their test of significance, they established their p-value as less than 0.5. And then lastly, one thing that you would also always want to be mindful of for any type of research, and that are the ethical concerns. And they do state very clearly up front that they sought IRB approval. Even though this is a retrospective study design, I'll say that in today's research, when you're publishing, it's very important that you seek IRB approval. Even though, again, this is retrospective, they were collecting protected patient information, and so it's just as important to seek out this approval for ethical concerns as if it were a prospective study. So that is not an issue here. Okay, so looking at some results here, they have a table of that outlines the demographics and some of the characteristics. So maybe you can get a bigger screen than what I see, but it's on page 4 of the article if you have the article in front. But essentially they list out all the different data variables that they collected: the Apache score, in-hospital mortality, age, female or male, the race, the total total treatment administration, discharge diagnosis, and then lastly was VAP noted, and how many days were they on mechanical ventilation. Now, there's 3 different columns here, actually 4. The in terms of the numbers here. So on the total, they're giving you the values of all patients that were receiving MDI in vibrating mesh. So for the Apache scores, kind of want to look at this for a second so you can understand these results a little more. So we have a median score, because we're looking at interquartile quartile ranges. I'll try to say that clearly. And so the median number, if you can see, is 13 to 22 is the range. The median is 17. And for quartile number range, you will just go right down the middle there, and then have a measure that gives you quartiles from that point, and that's statistically a way of describing these variables that sort of have a sliding mean, if you will. So that's where the IQR comes into being. And so if I look at the MDI column, I see that 17 is the median number there, as well as for the vibrating mesh. And then that last column, the p-value or significance here, really we can even sort of eyeball that there's really no difference there, and sure enough, the test of significance was not significant either. In hospital mortality, we saw overall the number was 76 in terms of a percentage. And then for the meter-dose inhaler, 16, and then nebulizer, 60. Again, no test of significant there. And so I'll let you see, but the only one that was significant in terms of the variables collected here, and that was the gender. And the female gender was significant, but again, the age, the race, the Apache scores, things like that, they did not find anything significant in terms of differences of patients receiving mechanical ventilation when they will receive the MDI or the vibrating mesh. No correlations were found between either of these devices, and so that was, the main point of this table, I'll say, is looking for what led to any test of significance, and the female gender was the only one that showed any significance. Now we go to these regression tables, and there's two things, two tables. One is looking at the impact or the development of VAP, impacting the development of VAP. And then the table 3 looks at the days of receiving mechanical ventilation. So let's think about what a regression analysis of this is about. So table 2, again, the impact of developing or development of VAP. If I take the first factor that they list there is the device, and it says MDI versus nebulizer. And now they present a thing called an odds ratio. And then the last column on the right, the confidence interval, or the 95% confidence interval. Now, this is a way of looking at data to see if there's any association with one factor, and then I'm going to add another factor to it, and then a third, a fourth, and so on. So we're looking for prediction. This is how I sort of look at regression models. How well does the device predict the development of VAP? How well are the days on mechanical ventilation predict the development of VAP? That's sort of how you can read this. But looking at the odds ratio alone, what do those numbers mean? And generally, an odds ratio equaling 1 is that there's no effect of exposure or outcome. And so let me just an exposure would be sort of like the treatment exposure. So the odds that an outcome will occur given a particular exposure, like the device or the days on mechanical ventilation, compared to the odds of the outcome occurring if there was no device used or there were no days on mechanical ventilation. And so again, if your odds ratio is 1, then there's no associations between the devices and VAP. Now, if your odds ratio is greater than 1, then that does indicate that your exposure or the device, the days on mechanical ventilation, can increase the odds of the development of VAP occurring. So it's a positive. And as I look down that list, I see days receiving mechanical ventilation, the device, those are both obviously greater than 1. The age and sex or gender, those are greater than 1. So you can see how those are different things that have been loaded that do show a positive association, but we're not finished. Then there's also 2 other factors that are less than 1, and so that would be associated with a lower odds of the outcome occurring. So that's the odds ratio, and we need to know kind of what those numbers represent. And then when we go to the confidence interval column, this is looking at a range of significance, a possible significance, I should say. But just because something has a 95% confidence interval that it is significant does not mean that it is significant. You still need to apply a t-test or some other type of test of significance here. And in the article, they do tell us that the only factor that is significant for the development of VAP, and that is the days receiving mechanical ventilation. And that's Table 2. Now going to Table 3, kind of got the same type of test, but now we're looking for the outcome of impacting mortality. And so as I look at, they use a point estimate here. It's very similar to the odds ratio, but a point estimate. And all of those are positive except for the age and the sex here. It doesn't quite meet the 1 where there's no effect. But again, they looked at the test of significance, and the only one that was significant was the Apache scores, the Apache 2 scores. And so here we see, I should say the days receiving mechanical ventilation were as well. So there are 2 factors in Table 3, days on ventilator and the Apache 2 scores. So it kind of gives us a way of predicting here that the days on ventilator that was seen on both, I'm going back to the Table 2 here, and going now to Table 3, days on ventilator were predictive of an increased incidence of VAP. All right, so what does all this mean, these 3 charts that we've kind of spent a little bit of time on? Well, as you begin to write your own discussion or you read discussions, a good thing to do is to be able to draw your conclusions back to what's in the literature. Does the literature support what you are finding with your results, or is it adding to another layer to what's known in the literature? And so as we start here, let's again look at what we are seeing. No difference in days receiving mechanical ventilation or in-hospital mortality for either the MDI or the vibrating mesh. Again, those 2 charts we just looked at, as well as Table 1 with the incidence of VAP, and there was no significance there of the devices whenever that was used as an outcome here. And so now let's look at what has been noted before. We have seen a higher delivered dose as possible with the small volume nebulizer versus the MDI. And this particular study that they're quoting, the sample population was patients who were receiving mechanical ventilation. And so if you look at this study here, there was no noticeable differences in vent days when you looked at MDI versus vibrating mesh. So the authors are saying here, we're adding a little piece to the puzzle here because we've looked at MDIs versus vibrating mesh this time. Same, patients in both studies here are on mechanical ventilation, but we have just looked at a third type of device, not just volume nebulizers and MDIs. Another outcome that they are trying to tie, they're explaining why they're saying what they are here, that, again, no noticeable differences. And this lack of outcomes can be sort of attributed to proper delivery technique for administering the treatments, or the MDI doses are adjusted to elicit a response, or they are adequate. So they're sort of saying, okay, this is what we are tying together, but we have to be sure that we're actually comparing what happened before to this study as well. So clean technique is used, and that's what they're referring to the proper delivery technique. All right, looking further in the discussion area, how do these findings relate to previous ones? Again, here we really zero down because a bench study noted from the literature, a bench study noted similar results between these two devices that were used in this study. And there's no difference in VAP. It's known that MDIs reduce bacterial contamination. We mentioned that before. And the vibrating mesh located on the dry inlet side has less manipulation and therefore can lead to less risk of VAP. So again, they're sort of tying what was known to what they have learned from their results in this study. And so here's where really, the so what of this article really comes forth, and how should these findings impact practice? Well, they mentioned the mechanical ventilation bundles that ICUs have been following for some time now, and the clean technique that goes with using these, with the bundles and with the devices that were used in this study. And they are saying that, because we're using these mechanical ventilation bundles and because we are so conscious of clean technique with these devices, that we do see an impact in practice here, because the increase in VAP is expected with higher mechanical ventilation days, but, that was noted, but higher PACHI scores can also be attributed to more severe, and this has also led to mortality. So they're going back to their prediction models of Table 2 and 3 particularly here to show that, the longer a patient's on the ventilator, then the higher their incidence of VAP and mortality. So their results are consistent with what has been known, and it does impact our practice. And then they sort of get to what additional work, or what is the future studies needed here. Additional work can be, again, to repeat this study using the new tiered terms of VAP, not the CDC guidelines, and they go into what that means, particularly with these ventilator-associated events. It's not just VAP anymore, but it also includes ventilator-associated condition and any infection-related ventilator-associated complications. And we have evidence to support 1 and 2, meaning the ventilator-associated conditions and infection-related ventilator-associated complications, but not VAP. And that then goes back to the results here where VAP was not significant, as we saw from Table 1. So, there's more work needed in this area for sure. Any study limitations? They do talk about the 50 patients that were in the MDI group, and it kind of goes back to my question when we first talked about the methods, about the power analysis. And so, there is a question here of perhaps because it was so skewed, you only had, less than 50 patients in that MDI group, that maybe the study population was underpowered. But they do talk about how, the conversion here really has led to less MDI treatments being given since that conversion occurred, and maybe that is a limitation here that, again, that we're not more to compare to the vibrating mesh. They mentioned the VAP odds ratio of 2.9. As we just discussed, anything over 1 does kind of lead to a positive or more odds here, a positive ratio there. So maybe it is clinically important, but it was not significant. Therefore, you have to ask is the VAP greater in the MDI group? And again, with the smaller sample size, we'd have to really kind of go back and retest or look at it in a different way. Also, with the retrospective study design, since we're going back into history, if you will, it did lack randomization. And we also don't know, the reasoning behind some of the decisions made for patients as well, because not everything is documented that way, and it's hard to kind of know what happened at times. And, this leads right to the next one. How were the aerosol treatments given? There were protocols in place, but were they always followed, or, we just don't know any of the little nuances that happen in patient care. And even though the patient still met study inclusion, that doesn't mean that they were all being treated exactly the same. So that's a limitation here. And the data is only as good as the data that you're able to collect. And then lastly, the dosing of the albuterol was not controlled. We talked about the number of medications and, was it indicated. There were protocols to discontinue the aerosol use once the patient had showed no further symptoms of indication. So, did all those things happen as scheduled or as they were supposed to? Sort of questions that you have to ask, and just, state these as potential limitations of the results. There was an editorial that came along with this, and Professor Tim Gilmore from Shreveport, Louisiana University there, his editorial, does this article really matter? And I kind of like that title that he gave. And he sort of laid out some evidence here of what, again, is known. And he goes back to the pressurized MDIs are a good alternative to traditional nebulization. And then he even talks about how the cost of HFAs, which is the propellant in the MDIs, is high in terms of cost, and there are really no cheaper options. For those of us who've been around, we remember when the CFC, or the chlorofluorocarbons, were the propellant de jour, and those have been all phased out to the HFAs, and a lot of patients noticed that difference if they were on the old propellant to the new, but now we're seeing where the cost of this propellant is very expensive. Another point that Professor Gilmore makes is it's believed that the MDI is the preferred method during mechanical ventilation due to the premise that these are less likely to contaminate the patient or the circuit there, and therefore there's less incidence of VAP. But then he says, well, there was no difference in this study here in VAP occurrence and ventilator days or in-house mortality. So what additional variables need to be considered? And he mentioned the deposition of the aerosol being delivered. Now, this study did not look at aerosol deposition. There have been studies in bench research and laboratory research that tries to simulate this, but in terms of patient data, patient outcomes, we really don't have that. And he is making the argument that this is something to consider. He also says that contaminated aerosol reservoirs are known potential risks for VAP, and certainly that needs to be considered in practice. And lastly, there's no research on contaminated aerosol devices and whether or not that increases the development of VAP. So he's bringing up even other questions that were not mentioned by the authors in the article. And lastly, he goes on to say, Dubosky and others, they did not specifically report ventilator-associated events. So he's making note of the definition of VAP that was used versus the nomenclature of terms that we know today. And again, he's saying, shift away from VAP as a quality indicator, and now use the ventilator-associated event incidence as your quality indicator. So he's given some advice for our practitioners who may not be, as these researchers in their hospital setting, doing actual chart review and retrospective studies, but he's giving some advice for practitioners, and I'm sure some of you are already doing that. Goes on to say the vibrating mesh may provide a safer alternative for aerosolized medications on mechanical ventilation, and the vibrating mesh does not introduce additional flow circuit because it remains on the dry side of the humidifier. Sorry for that typo. And so with these points of view and other advantages about particle size being consistent with the vibrating mesh, there's less condensate that develops. Again, it's on the dry side. And then the residual waste is negligible. And then he ties it back to the literature where, bench models have proven that the vibrating mesh to be superior to the traditional jet nebs and mechanical ventilation, and that the shared canister versus single canister, that is something to really consider because it is cheaper. On the other hand, to consider these MDIs, it is cheaper and may result in some ventilator-associated events. And the bench models show 2 to 4 times increased drug delivery on the models, but when you actually try to simulate these, it can very much vary in their operation. So what we see in the bench models may not always translate to patient care. So he's just kind of telling us, be aware of this, but he does see the author's conclusions in this retrospective design again, that there's no difference in the days of mechanical ventilation in hospital or VAP, and that the providing care based on sound evidence as cost lowers in competition of our aerosol devices, that the case can be made that the vibrating mesh is the device of the future here, and that it does not have some of the cost disadvantages or impediments as it once did because of the high price here. So some final thoughts here. How do you think this should affect practice? And is it time that we change the way we've always done things? This is what Professor Gilmore is asking us. And the take-home message he leaves, that it's imperative that clinicians remain astute in providing care with the greatest fidelity. That's based on the sound evidence here. So those are some thoughts from the editorial there. So I'll add one of my own comments here in terms of the title here. So let's look at the title one more time. Vibrating mesh nebulizer compared with meter dose inhaler in mechanically ventilated subjects. If I had been reviewing this, I would probably say, let's rethink the title here, because when I first read this, I didn't get anywhere that we were really going to be discussing patient outcomes. And so, I think this is important for researchers whenever you have a publication that you're putting forth, that the title kind of does lead the reader to your point here. And maybe I would have said a comparison of vibrating mesh nebulizers and metered dose inhalers, and then a semicolon, mechanical ventilator days and in-home mortality. So I would have, suggested a little hook there to fully capture what the article was about. But nonetheless, it was a very good article here. So at this point, I'll turn this over to Doug and be happy to answer any questions that may come up.
Well, fantastic, Lynda. This was a beautiful review of the literature in this article. Obviously, your knowledge of research and aerosol delivery is quite evident here. We do have some good questions, and it seems that most of them are, many of them are all kind of bundled into the same category of ensuring consistency in the delivery. So one of the questions asked about the circuits. Were the ventilator circuits consistent throughout the study?
You know, that's a good question. The authors did not go into any detailed specifics about that. So I would have to surmise that it was your typical inspiratory limb coming out from the humidifier to the patient, and a Y being there, and then the expiratory limb going back into the machine and through a filter. Other than that, there was really no description of the circuit used, so we'll assume a standard mechanical ventilator circuit for an adult patient.
And then a follow-up question that kind of impacts delivery speaks to the location of the delivery devices within the circuits. Where were the meter dose inhaler treatments administered from within the circuit, as well as the mesh nebulizer treatments?
Right. So the pressurized MDIs, those were delivered near the Y. They were within the 15 centimeters of the Y on the inspiratory limb. And the vibrating mesh, it was on the dry side, so meaning the short piece of tubing going from the ventilator to the humidifier. The nebulizer was inline there, and the medication cap was opened, the drug delivered into the medication cup that way, and then reclosed.
Okay, and then Christopher had a really insightful question. He says, particle size and droplet consistency during the time of delivery is one of the greatest benefits of the mesh nebulizer system and has a potential to affect outcome. Is this, in your opinion, something that should be included in further research?
I do, and I agree with you. That vibrating mesh, the particle size is consistent, and they have been able to demonstrate this through video and other means. So I do agree that it is probably one of our most promising devices right now in terms of aerosol delivery.
And I know that you just in some of the most recent slides, right at the end of your presentation, you talked about some of the discrepancies in dose delivery. And one person, maybe this is more of a comment than a question, but talks about with meter dose inhalers, is it a set number of puffs? Is it a set number or dosage, or is it dose to effect that may very well have an impact on the delivery of a meter dose inhaler, and could that potentially impact the results?
I totally agree that would impact the results, and the authors do speak to this. You know, I had a little bit about that in a slide that, you know, are you dosing to elicit an effect, or is it just a standard dose that was ordered, or are you giving it more often until you see results? I mean, there are a lot of, we know, clinical different, I'm losing the word here, but there are a lot of different clinical situations that we use this dosing maneuver, if you will, in different ways, depending if it's an asthmatic or you know, whatever is causing the tightness there. So the authors do speak to that, and I do think and agree with the writer that the dosing effect can definitely change this, and we don't know for sure. We do need more study in that area.
Okay. Well, out of respect for everyone's time, I will ask just one more question, and it comes from Craig. He says, regarding particle size, will the vibrating mesh delivery be reduced in the dead space from the dry side of the patient?
Oh, wow. On the dry side of the patient here, yeah, I just have to say I don't know. I don't want to kind of go any further than that because I'll probably say the wrong thing, so I don't know.
Well, Lynda, thank you. Lynda, I have that relationship with you, but it's really Dr. Goodfellow. I appreciate everything that you've I've appreciated everything that you've contributed today. As I said, your expertise in the area is obviously very evident. But thank you again for joining us, Dr. Goodfellow. We invite you to join us for the next webcast on Tuesday, April 25th, when our guest, Bill Galvin, provides a session regarding patient education. Please also join us for the next Respiratory Care JournalCast on Friday, May 19th with Mr. David Wheeler. Thank you for joining us, everyone, today, and have a fantastic weekend. Thanks, Lynda.
Thank you.
Excellent. I think that's all the time we have for today. Thank you to Lynda for sharing her expertise, and thanks to our participants for your interesting questions. In just a moment, you'll see a Submit Credit button appear on your screen. If you're an individual who is registered for this program, you'll go through the credit submission process on your individual account. Should this button not appear, please navigate to the Credit tab and select the Credit button linked. If you are a group participant, please have your group leader submit your information to the Group Attendance tab to be provided with follow-up instructions on how to submit for credit. This concludes today's presentation. To simply exit out of the browser window. We hope you have a great afternoon.